Good morning. Thank you for joining us for Grand Rounds. So a few years ago, well, perhaps a little more than a few years ago, when I was a medical student in India, I rotated through a ward that was full of patients with Berger's disease, thromboangiitis obliterans. And if you haven't seen it here, it's because it's probably more prevalent in South Asia and the East. And it's basically vasculitis, if you will, related to nicotine consumption in the peripheral vessels, small vessels, both arteries, veins, and the nerves of the hands and the feet. And that's when I realized just how addictive nicotine could be. And an image that is seared into my brain and still vivid to me 38 years later is that of a young man in his 30, 38, 39, 40, who had his fingers amputated and his toes also incidentally amputated for gangrene. And he had gotten a ward boy to light a bidi, which is the indigenous cigarette in India. And he was holding it up with his wrists to inhale the smoke through his tracheostomy. So that's one of the reasons pulmonary medicine was attractive to me back then. And so this is an incredibly important topic, smoking cessation, and that's why it's so important to discuss this and put this into practice every day when you see a patient who's a smoker. So it gives me great pleasure to introduce Dr. Radhika Shah. Dr. Shah obtained her bachelor's degree in biology from the College of New Jersey, and then her medical degree from Rutgers, and was a resident at Yale, and followed that up with a fellowship in pulmonary and critical care from the University of Maryland. She's an assistant program director of the internal medicine residency, as well as an assistant professor in pulmonary and critical care. So welcome, Radhika. And she's, by the way, the mom of a proud pandemic baby. And I was hoping for pictures, but apparently not.
All right, anyone can ask for pictures at any time. All right, so I'm going to be talking about smoking cessation today, and I wanted to thank Dr. Koo and Dr. Minardi for brainstorming this with me on this topic. Initially, I was a little bit reluctant about talking about this because I was like, everyone knows Chantix, patches, whatever. It's not new for people, and it's not something that people need to improve upon. But as I was going through the details of this talk, I realized I had learned a lot of things and nuances regarding prescribing pharmacotherapy for smoking cessation. And I realized that there was plenty of room for improvement. And if there was for me, then hopefully a Grand Rounds audience will have room for improvement as well. And it is such an important topic, as Dr. Sethi mentioned. So the objectives of my talk are to review the health benefits of smoking cessation. I will briefly describe the communication and counseling methods available for aid in smoking cessation. But I will try to spend most of my talk talking about the reviewing the current evidence and strategy for pharmacotherapy and smoking cessation. And then just to take some mental breaks for this talk, we will learn some tobacco-related trivia along the way. That will be indicated by a Baby Yoda meme, in case you're wondering what we're doing off topic as we kind of go through this presentation. And if you're not a Mandalorian fan, we have a little Game of Thrones reference as well later on. All right. So what's the degree of the problem? So in the United States, in 2018, 13.7% of adults were smokers. This number has been going down over the last decade, but it's still too high. When we look at Tennessee specifically, 20% of adults are smokers. So another way to look at it is 1 out of 5 adults are smokers. That's, again, a really high number, and it is higher than the national average. 20% of youth are smokers of any type of tobacco product, including e-cigarettes. So again, there's a huge problem in our local community, and is definitely something that you want to be an expert in being able to evaluate as well as treat. Okay, our first mental break. So in Tennessee, tobacco products have a tax. Tennessee ranks the 43rd in terms of how much tax that they place on a pack of cigarettes. So Tennessee, the average state tax is 62 cents per pack of cigarettes. In the United States, just to give you a rough idea, it's $1.82, the average tax. And any guesses on what state might have the highest tax? Good guess. It's District of Columbia. It's $4.50. So don't buy your cigarettes from there. All right, so let's back to our presentation. So why does smoking cessation matter? It is time consuming to talk to a patient about smoking cessation in your clinic visits, in your hospital visits. So is it worth it? Is it worth talking to them about it? So there have been multiple studies kind of looking at whether smoking cessation actually has an overall outcome for patients. And so the lung health study is one of the landmark trials that looked at the effect of smoking cessation and mortality. They randomized 3,900 patients to the special intervention group versus a usual care group. So special intervention group was a group of patients who got nicotine replacement therapy and intensive counseling for smoking cessation. And then the usual care group just kind of got, please quit smoking and then kind of move on. They only took COPD patients, so we'll get to that later, patients with obstructive lung disease. And then they followed them for 14 and a half years to see their mortality and as well as if they were able to quit smoking. And they found that the special intervention group had a significantly higher number of sustained quitters, 21% versus 5% in the usual care, and that the mortality was significantly less in the special intervention group compared to usual care. And for those who are visual, in this graph on the x-axis is time from the lung health study baseline, and then on the y-axis is the proportion of patients who had no events. And so you'll see that it's 100% at the beginning of the study and then declines. And you'll see that on the dotted line is the usual care group, which declines faster than the solid line, which is the special intervention group. So in conclusion, it looks like that when you have patients who are sustained quitters in terms of smoking, that you're able to make an impact on mortality. And this has been replicated in subsequent studies. This was just the first big landmark trial to study this. So the results of this study, as a particular limitation, only applied to subjects with obstructive lung disease. There have been subsequent studies where they've expanded that population, but a limitation of the study would be that, is this really generalizable to the smoker who may not have any medical problems yet? In the lung health study, the subjects that were younger than 45 had the greatest benefit, and there were significant differences in death rates in patients from lung cancer and cardiovascular disease for those who quit smoking. So some key points here that would help you in terms of counseling your patients when you're talking about smoking cessation and targeting your younger patients, because they're going to, again, have a greatest benefit in terms of mortality. Okay, so we've talked about how smoking cessation is going to make an impact on your patient's health overall. So what tools do we have in our toolbox to help patients to be able to quit smoking? And so I divide that up into behavioral and pharmacotherapy. In the behavioral category, I'm going to focus on the provider message. So that's the clinician's role in giving the message that this patient needs to quit smoking. The other resources, I'll give you some information on how to refer to that, but refer patients to counseling, telephone-based and web app-based resources for behavioral interventions for smoking cessation. But as the provider, your job is to connect them with those resources, not necessarily to be the person doing those actions. And then the other job of the provider is to provide pharmacotherapy. And so we'll go over that also in more detail as well. So let's talk about the provider message. So there is a technique that is recommended to use when you're the provider that's recommending to the patient to quit smoking. And the classic traditional strategy is using the 5 A's. And so the US Preventative Task Force puts out guidelines every few years for smoking cessation. And so they are the traditional, have the traditional guidelines that provide strategies for providers to help patients to quit smoking. So they talk about the 5 A's, and this is very traditional. So you guys probably learned about this in medical school. So you ask about tobacco use, advise to quit smoking, you assess readiness to quit smoking, assist smokers to quit, and then arrange for follow-up. The recommendation from the society is that this should be brief. You should be able to go through this process briefly and be able to provide the resources for your patient that they need. So like I said, smoking cessation counseling, even though it's brief, it's still something you got to do in your busy clinical lives. So you want to know that what you're doing is going to make a little bit of a difference. So as you can imagine, studying whether this strategy to give your provider message is actually effective is a little bit difficult to do, but there have been some studies to look at whether or not doing a brief cessation intervention using this method actually gets patients to quit smoking. So I couldn't find much on whether the 5 A's actually causes patients to actually quit smoking, but this study does look at whether when providers provided all 5 A's of the smoking cessation intervention, whether or not patients actually sought out resources for quitting smoking. So this was a survey-based study, and so they sent surveys out to patients asking them if their health providers actually went through all 5 questions of this strategy and whether they actually sought out any additional resources for smoking cessation. And so they found that the odds of patients actually seeking out counseling, medication, or both counseling and medication were significantly increased for patients who actually received all 5 questions of the smoking cessation provider intervention. And so it seems like, by actually going through this, that patients will seek out further help for smoking cessation. Again, whether it actually results in smoking cessation itself, it's unclear. But both the American College, so I'll refer a lot in this presentation to 2 other smoking cessation guidelines, the American Thoracic Society and the American College of Cardiology, which both have come out with pretty good guidelines in the last 10 years, actually last 5 years, for smoking cessation, and they match up a lot. So I'll refer to kind of both of those guidelines. So both of them actually also recommend using the 5 A's for smoking cessation strategy, but they actually recommend that the assessment be not readiness to quit smoking, but actually assessing the degree of nicotine dependence. So their point is that nicotine dependence is a chronic relapsing disorder. It is a disease process that you need to treat. So when you treat somebody for diabetes, you don't ask them, are you ready to start metformin? You just say, here's some metformin for your diabetes. So, and they can opt and they can say, I'm not ready to take it if they want to, but most of the time our practice is not to ask patients if they're ready to start being treated for a chronic disease. And so their point is that we should be treating nicotine dependence the same way. And instead of assessing patients' readiness to quit smoking, we should just be assessing how addicted they are to nicotine. So that's a pretty big paradigm shift. And I feel like I'm going to give you that recommendation, but anecdotally, I feel that in the culture of tobacco use, a lot of patients know that they need to be ready to quit smoking in order to go through the process of quitting smoking. And so I can imagine, as I was writing this talk, I actually tried this on some patients and it doesn't go well. And so they're like, well, I have to be ready and I'm not ready. And so I'll give you the recommendation, and I think it's a really nice framework to think about smoking cessation. But I think practically, it's really hard to implement because patients know they need to be ready, and they know that's part of the culture of smoking cessation. But both societies recommend this. But if you are looking to assess the how heavily patients are dependent on smoking, you can use this index, and this is the heaviness of smoking index. There are other like questionnaires. They're longer. They're not as well validated. Most people like this because there's only 2 questions. How many cigarettes a patient smokes in a day? You're already pretty much asking for your pack year history. So the only new question would be, how soon after waking up do you smoke your first cigarette? And so if you are smoking it within the first 5 minutes, you're more heavily dependent compared to if it takes you over an hour to smoke your first cigarette. And so they've looked at, actually, there have been a few studies to look at if you have patients who are heavily addicted, who are using cigarettes right at 5 minutes, their risk of relapsing from smoking cessation is higher, and their likelihood of being able to quit is lower. So it does help with that, and can maybe help you decide on your resources and how you want to treat a patient depending on how dependent they are. So you can use this tool when you're assessing for nicotine dependence. Okay, so that's my, that's kind of what I wanted to talk about the provider message, and consider asking your patients about nicotine dependence and how heavily they are addicted, and try to use the 5 A's for every intervention, every patient that you see who smokes. So briefly, I wanted to go over the other behavioral interventions that are available for patients, and that includes individual and group counseling, telephone-based resources, and web app-based resources. So I'll tell you that in terms of individual and group smoking cessation classes, so we have, for kind of like a brief counseling, individual counseling, we do have the respiratory therapy navigators in the hospital here that will come and individually like counsel patients on smoking cessation. It's not something that happens like repeatedly, but it is an intervention that we have here. Unfortunately, with COVID and stuff, I think groups smoking cessation classes have gone through the wayside at Erlanger. And so that's something we just checked last week. And so that's something that kind of needs to get back going again. But both of those resources may be available depending on what institution you're working at for patients. I feel like the telephone resource is probably the most accessible for patients. And so 1-800-QUIT-NOW basically got its start around in 2006. And it is a national quit line that then funnels patients to the state quit lines. And so for Tennessee, they do provide free nicotine products when patients do the intake phone call. So I like that it's accessible because it's a phone call. The patients don't have to go anywhere, but I also like the fact that you can kind of get a patient to try it out by saying you get free stuff. So that's kind of the way that I try to get patients to at least get connected with it. And then after the intake call, they get set up with a counselor, and then they get like subsequent phone calls after that for to help them with their smoking cessation and strategies. For patients that are interested, there are web and app-based resources, smokefree.gov for a little bit more like literature and strategies to quit smoking. And then 2 big apps that are out there are Quit Guide and Quit Start. If you have a patient that's going to do well with that type of thing, you can try that. People have studied the apps that are out there for smoking cessation, and they find that there's a lot of variability, and it's not very evidence-based, the stuff that they have in those apps. And it's also not easy to find when you try to search them on the App Store. So it's not, it is a resource out there, but I don't think it's the best. So I would recommend that the telephone-based resource is probably the best in terms of a way to connect patients to some sort of behavioral intervention for smoking cessation. All right, so before I go to pharmacotherapy, so a little break. So there is cigarettes, but then there's also smokeless tobacco. And it's something that we should be asking our patients about, because there is still significant health risks to using smokeless tobacco as well. And so just so go over some terminology. So patients can do loose chewing tobacco, or snuff, both of which cause a lot of salivation, require you to like spit it out in like a container or something like that. You can also snort snuff, and that's commonly used. Snus and dissolvable tobacco come in flavorings. Snus is like contained tobacco packets that you can put like between your cheek and your gums. And they can come in a lot of flavors. And then there's like dissolvable tobacco, which kind of dissolves in your mouth, also comes in flavors. Flavors are a big issue in the tobacco industry, and we'll talk a little bit about that a little later as well. But just in case people don't know the terminology, I just wanted to go over that. All right, back to our presentation. So now we'll go over the pharmacotherapy that's available for patients that you can prescribe to help them to quit smoking. So there are only three main FDA-approved medications for smoking cessation. There's nicotine replacement therapy, Varenicline, otherwise known as Chantix, and bupropion, otherwise known as Zyban. So nicotine replacement therapy is basically exactly what you would think. So it is administering nicotine to offset what you would normally get from a cigarette. And so nicotine binds to nicotine acetylcholine receptors. And when you smoke a cigarette, it releases neurotransmitters that are basically make someone feel good. It increases mood, it increases attention, it increases just energy. And so all of those pleasurable feelings come from and come in a rush when you smoke cigarette. So the nicotine replacement therapy is to administer that nicotine in a more controlled fashion so that you prevent withdrawal, but are still giving, but you're not kind of causing that rush of great symptoms. And so that's kind of the point of nicotine replacement therapy. So these are the formulations that are out there that you can give to patients. The recommendation is that you do some sort of controller medication, which is generally your patch, and then an as needed medication for additional cravings on top of that. So there's many options for that. So gum, lozenges, inhalers, nasal sprays, and then dissolvable tablets. You'll notice that there's nothing where you actually swallow a pill for nicotine. And so the reason is that nicotine goes through first pass metabolism through the liver. So it wouldn't be effective in actually getting nicotine to the brain. So this is all through mucous membranes, if you notice, that you get nicotine into the bloodstream. When you're prescribing these products, keep in mind that a pack of cigarettes a day gives you 20 to 30 milligrams of nicotine. And the nicotine patch, the highest dose is 21 milligrams. So if you can imagine somebody who smokes 2 packs a day, I don't know how much a nicotine patch is going to cut it. And then if you think about it also, the recommendations like on the packages for like Nicoderm and stuff like that is that if you smoke more than half a pack of cigarettes a day, they're already recommending you do 21 milligrams of the nicotine patch. So again, it's unfortunately the doses seem like they're a little low for people who smoke more than a pack a day. But that's how you prescribe the medications. They're over the counter, but that's how you would recommend the medications. So does nicotine replacement actually work? So as I go through the pharmacologic agents, they all have really good Cochrane reviews on their efficacy. So I will refer to that. And they all have pretty recent ones in the last like 5 to 10 years. So nicotine replacement therapy, its Cochrane review came out in 2018, where they looked at 131 trials of various nicotine products. And they found that the relative risk of being able to be abstinent at the 6-month mark of the smoking cessation intervention was significantly, was statistically significant for all of the nicotine products. And so if you for most of them, for some of the combination ones, there are some that are not statistically significant, but I think those studies were really a lot smaller. So when they combined all the trials, the relative risk combined was 1.5. So in layman's terms, when someone receives a nicotine replacement product, they're 50 to 60% more likely to quit smoking, would be how you would describe that. So it is effective compared to doing nothing. So in terms of smoking cessation. So if you decide that you want to offer your patients nicotine replacement therapy, how do you want to counsel them? You don't want to just say, you need to start a patch. You know, if something happens or they have a side effect, they're more likely not to use it if you haven't warned them about it. So for nicotine replacement therapy, the way that you want to counsel your patient is that they want to start nicotine replacement on their quit date. You want to use a combination of a patch and a short-acting agent. And a common side effect of these products is local irritation. So you can get skin reactions from the patch, and you can get like oral irritation from like the gum and lozenges and things like that. Another tip is that, especially for people who use the gum is not really meant to be like chewed all day. It's supposed to be chewed a couple times to release the nicotine, and then placed between the cheek and the gums to sort of have it be absorbed. So a lot of patients will like complain that nicotine gum and lozenges taste really bad. And that's because, and so part of that is they shouldn't be chewing it all day. They should just be sticking it in their cheek. Another strategy that I use a lot for nicotine gum is that I will tell them to have another piece of flavored gum with at the same time, and so that they're not like just tasting the nicotine. So that's another strategy. Okay, so our next agent is Varenicline, or Chantix. So Varenicline is a partial nicotine cholinergic receptor agonist. So certain types of the receptor it will stimulate, and then certain subtypes of the receptor it will block the dopamine. And so between those two effects, Varenicline will help to decrease nicotine withdrawal, but it will like block any effects of any of the pleasurable effects that nicotine has. And so that's the way that it works in terms of smoking cessation. Chantix comes in 0.5 milligrams and 1 milligram tablets. And the way that you prescribe it is you start off with 0.5 milligrams for 3 days. You ramp it up to twice a day for 3 days, and then to 1 milligram twice a day as your final maintenance dose. The treatment length is generally recommended as 12 weeks. And we'll talk about whether or not you can extend that a little later in the presentation. And the main contraindication to Varenicline is just if you've had an MI in the last 2 weeks. So Varenicline's Cochrane review came out in 2016 to look at the efficacy of Varenicline versus different agents and whether or not it was successful in getting patients to quit smoking. And you'll see that when you compared Varenicline versus placebo, the relative risk of quitting smoking was 2.2. When you compared Varenicline versus bupropion, it also was significantly better than that medication. And then Varenicline versus nicotine replacement therapy, the relative risk was also statistically significant at 1.25. And so it seems like Varenicline outperforms placebo, bupropion, and nicotine replacement therapy. And again, we'll talk a little bit more about that also a little later. So if you choose to start a patient on Varenicline, how do you want to counsel them on the side effects and how to use the medication? So you want to tell the patient to pick a quit date 7 to 35 days after starting the medication to allow the medication to build up. So I didn't know this before doing this presentation. They should be taking it with a full glass of water or food to minimize nausea. And nausea can be a limiting factor for patients to continue to take the Varenicline. And then side effects common are nausea, headache, vivid dreams, and mood. Now, anecdotally, I feel like the vivid dreams and mood issues are a really common reason for people not to take the Varenicline anymore. I feel like it's like not really, they don't really talk about it much in the literature, but it's literally the only thing that people will not take the Varenicline anymore for is because it quote unquote made them crazy, or it caused them really, really, really vivid dreams. And so I try to warn patients about that when I prescribe the varenicline, just so that they're not super surprised by it and that maybe they'll push through it a little bit longer from the side effects. But I would encourage you guys to tell patients about it ahead of time, because it's also a pretty unique side effect as well.
Can I interrupt a second? Mm-hmm. The FDA used to have a black box warning for suicidal thoughts. They've gone back and forth. I think today it's not there.
It is not there, yeah. And actually, I'll talk about that trial a little later. But they do talk about, they did do a huge study called the Eagles trial, I think it was 2019, where they compared varenicline, bupropion, nicotine replacement, and placebo. It was like 4 arms. And they looked at the neuropsychiatric adverse effects in all 4 arms, and they were not statistically significant differences. And so they took away all of the psychiatric warnings for all of the medications. So that is not, yeah. Mm-hmm. Yeah. Mm-hmm. It was like it was a big study. There were like thousands of patients. So. And all of the American College, now that I think about it, also the American Thoracic Society and their guidelines specifically addressed that question of patients with previous psychiatric disorders and like suicidal ideation and things like that. And they also recommended that that is not something that you should, because the risk of smoking is so much higher for those patients. And it's more difficult to quit smoking as well in that population. Okay, so just briefly, there is a Varenicline recall right now. So there are high levels of nitrosamine impurity in the current Varenicline stock. So the FDA has approved the Canadian generic as a substitute. It's called Varenicline, and it's really funny because it's called Champix. So, but it's the same. Just when you prescribe it for patients, just make sure you tell the pharmacy to allow substitution or prescribe Varenicline. Okay, so the last agent is bupropion, which is an atypical antidepressant and that is a nicotinic receptor antagonist. It is usually prescribed as 150 milligrams daily for 5 days, and then you ramp it up to twice a day. Again, the traditional recommendation is a 12-week treatment course, and contraindications and warnings for this include seizure disorder, anorexia, bulimia, bipolar, and MAOI use in the past 14 days. The anorexia, bulimia warning is more for if you have like electrolyte abnormalities and dehydration, things like that, you're more at risk for some of the side effects with bupropion. So that's why that's on there. Okay, so its Cochrane review came out in 2014, where bupropion was compared to placebo. And at 6 months, it had a significantly increased effect on smoking cessation with a relative risk of 1.6. They also compared adding nicotine replacement therapy to it versus just nicotine replacement alone. And it did not look like it outperformed nicotine replacement therapy when you use the combination. Okay, but if you compare bupropion and nicotine replacement therapy head to head, it actually also doesn't outperform nicotine replacement therapy. So the thought is that bupropion probably is about similar efficacy as nicotine replacement therapy, and that varenicline is probably more, but it is still a tool in your toolbox for sure. So when you are counseling your patient, you want to start with a dose of 150 daily and then increase to twice a day. Set a quit date you're going to ask the patient to set a quit date during week 2 of treatment, and then counsel your patient on side effects. So it's a little better tolerated, I feel like, than varenicline. Insomnia and dry mouth are the most common side effects. Okay, so that's bupropion. Okay, we'll take a little break and then we'll talk about some frequently asked questions. So hookah is another tobacco delivery system originated in Persia and India. It's a very, very old tobacco delivery device, and it uses water to heat up the tobacco and then you inhale it. It has become it has been used increasingly in youth in the United States in the past decade. And there is this thought that because it goes through water that it's getting kind of strained and all of the carcinogens don't get to you when you inhale. But there has been some studies recently that it may, because of the way that people inhale it, might actually deliver more carcinogens than cigarettes do. And it also comes as flavors as well. So it can be more addicting for youth as well. So hookah is not better than cigarette smoking. So again, something to counsel your patients on, and if you didn't know what it was. Okay, so now that we kind of know all the tools that are in our toolbox for smoking cessation, how do we become versatile in using them and kind of knowing when to use which drug? And so we'll go over some common questions that kind of come up as you're prescribing these medications for patients. So one question would be, which drug works the best? And so based on all the things that kind of I talked about, it seems like Varenicline kind of outperforms the rest of the drugs. And so in the Cochrane review, when they compared the Varenicline placebo, the Varenicline bupropion, and the Varenicline and NRT, it outperforms all three of those medications. And this is what Dr. Cohen was mentioning. So this is the Eagles trial that looked at, it looked at all of these medications kind of head to head. And the point of the study was to look at the neuropsychiatric safety, but they were also able to look at efficacy as well. And so if you look at this graph, you'll see the amount of patients who had the percentage of patients who were able to quit smoking on all of these medications. So Varenicline is in the red, and then the rest of the medications are the other colors. And you'll see that at weeks 9 through 12, as well as weeks 9 through 24, Varenicline outperforms all the other medications, and it's pretty, and it is statistically significantly more efficacious. And then if you see bupropion and nicotine patch are in the blue and the green, they're like both similar on both of the graphs. And then both the American Thoracic Society and the American College of Cardiology in their guidelines also recommended that Varenicline be your first line for treatment for smoking cessation. And that should be what you offer patients first when we talk about smoking cessation. Okay. Next question that may come up: should you combine nicotine replacement therapy with Varenicline or bupropion? So we saw in the bupropion Cochrane review that if you combine it with nicotine replacement therapy, it doesn't outperform nicotine replacement therapy alone, but does it outperform bupropion alone? I couldn't really find much on that. And to be honest, bupropion already is not that effective. So compared to nicotine replacement therapy. So I don't think it's something that people want to study that much, but there have been studies on whether or not adding nicotine replacement therapy to Varenicline, whether that is more efficacious than just using the Varenicline alone. So there were in the last 10 years, there have been 4 studies on comparing these two, and 3 of them showed no difference, and then 1 of them did show a slight increase. And so this is from JAMA, and this was the one study that showed that maybe Varenicline has a little bit, with nicotine replacement therapy, has a little bit more effect on smoking cessation than Varenicline alone. So I would say that there is probably still a lack of data on whether or not that these two, this combination actually works better. But in all 4 of those studies, it didn't look like there was any issues with tolerating the combination or any serious adverse events. So both the American College of Cardiology and the American Thoracic Society, they both kind of say that you could do it if the single agent doesn't work. It's it may work, but it's definitely not harmful. So it is something you could try if the single agent is not working. Just keep in mind, nicotine replacement products are expensive. So if that's something to think about when you're doing these combinations for patients. All right, so how long should we treat patients? So I told you earlier that the traditional recommendations is to do 12 weeks of treatment for bupropion and for varenicline. But there has been some recent interest in whether or not extended duration of therapy would be more beneficial for patients. So the American Thoracic Society did a systematic review of 12 studies to determine whether or not extended duration therapy, and when we talk about extended duration, we're talking about 3 to 6 months, whether that's more efficacious than standard duration therapy, which is 12 weeks or less. And they did find that at 1 year that the percentage of patients who were abstinent was significantly higher than the standard duration therapy, and that it was not a statistically significant higher amount of serious adverse events. And so the question becomes, I think the question is, when you start off prescribing this medication, do you tell the patient expect to be taking this for 6 months, or do you give the patient the medication and say, we'll see how you're doing in 3 months and then decide on increasing it to 6 months if you're not doing well? There's no real recommendation on that. And so I think that the takeaway point from that recommendation is that for patients who are really dependent, when you ask your heaviness of smoking index and you find that they're using a cigarette right when they wake up and things like that, you may want to consider just having them expect that they'll be taking the medication for longer than 3 months, just to hopefully increase your abstinence rates. And so the American College of Cardiology recommends considering 3 to 6 months duration for varenicline and bupropion, and the same thing for the American Thoracic Society, but they have like a moderate recommendation on that. Okay, we talked about this. How do we handle e-cigarettes? Okay, so lots of patients will say, well, I'm trying to quit smoking with vaping. And so how do you handle counseling patients on that? So just a little history. So e-cigarettes became kind of the object of scrutiny around 2016. They started becoming popular. They started getting more popular in the United States in the late 2000s, but kind of really ramped up in 2015 and 2016. And that was with Juul. And the reason is Juul is a type of e-cigarette that uses a special nicotine salt that gets to the brain faster. And it is, and then they were also really good at marketing for social media and ads to the youth. And so it became really kind of on the FDA's radar because a lot of young people were getting addicted to Juul. And they have found that then they're more at high risk for using traditional cigarettes afterwards. And so this is sort of kind of the history behind the e-cigarettes. So recently now, all of the, not recently, in 2016, the FDA took all of the tobacco products under their jurisdiction just because of this issue. So there's been a lot of scrutiny about e-cigarettes and the tobacco industry marketing it as, well, use e-cigarettes to help you quit smoking. They're less harmful than cigarettes. However, they still have harms in and of themselves. And so all of the societies that come out with smoking cessation guidelines are very, very hesitant to recommend e-cigarettes as a way to quit smoking because they have their own issues. So there is some conflicting evidence that e-cigarette use improves smoking cessation attempts, okay? And so that's kind of how the tobacco industry took that and kind of ran with it. And e-cigarettes do cause a little less physical harm than combustible tobacco products when you talk about things like COPD and things like that, lung cancer. but there are reasons to not recommend e-cigarettes. It does increase risk of future combustible tobacco use if it's like your first tobacco product. The e-liquids can cause physical harm. You can get vaping associated lung injury too, and probably a lot of other things that we don't know about yet. They're highly variable devices, so you can't really control what's in them and how much nicotine you're getting. You can get explosions from the devices. It's rare, but it can happen. The other thing is that it replaces one addiction with another when you're using it for smoking cessation. So are you really treating the underlying issue is the question on that. Nicotine itself still it gives harm to fetuses and then youth and adolescent, especially for brain development. So even though it's not as harmful as a cigarette, it's still, the nicotine itself causes a lot of harm. And then when patients try to use e-cigarettes to help quit smoking, they often still use both types of products. And even just a few cigarettes a day increases your risk of cardiovascular disease. So when you're using e-cigarettes to try to help you quit smoking, you're really not solving the problem if you're still smoking a couple of regular cigarettes every day. So most of the societies are like, don't recommend this as a way to quit smoking. But if someone's adamant about it, you would recommend that they completely switch over to e-cigarettes. They shouldn't be smoking both if they really feel strongly about using it to help them quit smoking, but to counsel them on some of the negative effects of e-cigarettes as well. So just on that note, actually, the tobacco industry has, and as I was doing this talk, I like made this slide towards the end and realized that this would have been an interesting talk in and of itself on the evils of the tobacco industry. But I really wanted to give you guys something that was relevant for your clinical practice. But just as a quick anecdote, Marlboro and Newport dominate 80% of the tobacco industry market. And despite the decreasing use of cigarettes in the United States, they've a lot of money and increasing amounts of money over the past several years. And that's because of their investment in e-cigarettes. And so just like I mentioned, they've really taken off with those couple of studies where e-cigarettes kind of helped people to quit smoking. And they've been marketing that as a way of trying to get people to switch over from using cigarettes to using e-cigarettes. And then they've invested significant amounts of money into the e-cigarette business. I think Marlboro bought out Juul, owns 35% of Juul in 2019. So there's like a lot of shady stuff going on in the tobacco industry, basically, is what my point of this is. Also, they've increased the amount of flavors in e-cigarettes to try to target youth to get more addicted. And when you have a young person who's addicted to e-cigarettes, they're more likely to use a combustible nicotine product in the future. And so there's been a lot of scrutiny on some of the ways that tobacco industry markets to people. And, luckily, our societies like the American Thoracic Society, the College of Cardiology, and other industries under other societies have been really, I think the American Pediatric Association as well, have really been lobbying for an increase in the age of buying tobacco products. And so I think 2019, the age to buy tobacco products increased to 21. So that's one success or win against the tobacco industry. So not everything is just negative about the tobacco industry in the United States. We are making some headway. All right, so that is my strategies for smoking cessation. In summary, smoking cessation significantly impacts mortality and so is a worthwhile endeavor for your patients. Providers should perform a brief smoking cessation intervention using the 5A approach, and you can consider the assessment part of that as whether a patient is being, to include of whether a patient is ready to quit smoking and switch it to how dependent they are on nicotine. pharmacotherapy and behavioral therapy should be offered in combination. And then varenicline has the highest efficacy for smoking cessation when you compare it to bupropion and nicotine replacement therapy. So that should be considered your first line therapy. All right, thank you guys.
Any questions? I have a question about e-cigarettes. I thought there were some more recent guidelines about e-cigarettes in the U.S. being recommended for an aid in smoking cessation. But also just to take a step back with the concept of harm reduction, and like it seems like every one fewer cigarette is a step in the right direction for a patient. So if you can get them from 20 to 15, that's better than just not making any progress at all. So if we can use e-cigarettes as a way to like reduce their cigarette burden, or as if they can switch entirely. And then just also the idea of like switching one addiction for another, that's a common refrain from people who are kind of against methadone or Suboxone for treating opiate use disorder. And I just find that kind of language difficult with people who have severe addiction, like to nicotine, that it's probably better to smoke an e-cigarette. We know there's not a lot of data on long-term effects and the whole E-Valley issue, but just wondering what your thoughts were on that.
I guess the question is like, how much harm reduction are you getting? Because again, most of these patients who are using e-cigarettes to help quit smoking are still smoking regular cigarettes. And so again, if the addiction's still there, is the relapse, are they a higher risk for relapsing? And, you know, if you've gone down from 2 packs a day to 1 pack a day, how much like benefit are you really getting from that? And are you going to relapse back to 2 packs a day? You know, like, I guess, how much are you getting out of that? Whereas if you spend more of your effort as a clinician to try to get them on these medications, that might be a little bit better for you. So I think you have to feel out your patient. But I just don't think that people feel that there's enough evidence to say that I want to recommend e-cigarettes as a way to quit smoking. Yeah.
Thank you, Radhika. Excellent discussion. Just to dovetail into what Dr. Pamelia said, something more anecdotally that I found over the years that's been helpful to get a patient with momentum is to just have them regulate their tobacco. So I try to tell them that they could smoke on an even hour. So if it's 1:30 and they desire a cigarette, what can they do to distract them just to get them to 2 o'clock or 4 o'clock? And if they can go for a couple of weeks regulating it where they have that at 2 hours, they get momentum, they get kind of animated about trying to go ahead and extend that to every 4 hours and 6 hours and then 12 and then go off. So for patients who are really not ready to quit, just regulating it, I found through the years has been helpful to get people motivated to keep moving. So I think that is one way that I found helpful over the years. Excellent discussion.
Thanks, Radhika. That was really great. I was wondering if there is evidence about continuing to smoke while using these products, because I have a lot of patients who are interested in starting Varenicline or something, but aren't going to commit to a quit date. So I think you can continue smoking while on them, but more of the issue I think comes with smoking on nicotine replacement and whether you're actually going to end up using more nicotine than when you were just smoking. Do you have like a strategy for how much you can smoke while you're on the patch or anything like that?
I mean, I didn't find any like data on that, but if you kind of think about, you know, again, like in a pack of cigarettes, if you're getting 20 to 30 milligrams of nicotine a day, and it seems like if you've got a 2-pack a day smoker and then they are using the patch and using 1 pack a day of smoking, they're probably getting the same amount of nicotine. So I feel like you could probably kind of think about like how much nicotine they're getting in that way. And hopefully if they're able to at least reduce the amounts of smoking with their nicotine replacement therapy for a bit, that maybe the step in the right direction, but there's no harm. It doesn't seem like there's any like adverse effects with using nicotine replacement, using cigarettes while on any of these therapies. So, because there are a lot of patients who in these trials who were still smoking on the therapy and there were no changes in adverse events. So.
Hi, thank you for your presentation. This question about varenicline. Should you be cautious about prescribing varenicline if they've got some sort of seizure precautions?
The seizure precautions on the bupropion. It's not on the varenicline.
I was just reading up and I saw there was some contraindications as well, but I'm not sure if that's really been studied.
Not that I saw. Maybe there is, and then I didn't see it. But technically the warning is on the bupropion for the seizures. Yeah.
Any other questions?
Maybe more of a, thanks, I love your talk. More of a comment that pharmacotherapy can be expensive depending on patients' access to medication, what the copays are, and we're willing as a society to spend hundreds of thousands of dollars for their heart attacks or their COPD, but not having a $50 copay for some of these medications or replacement because it's over the counter. So penny wise, pound foolish.
Yes.
We don't have a good healthcare model.
Yes, I totally agree. And that was also another direction I thought about taking this talk. But again, that doesn't really help you guys when you're seeing a patient. But I've thought about that a lot, is that if someone would just cover this patient's Chantix, then, maybe their COPD wouldn't keep getting worse.
Are there any studies with regard to, I guess, leveraging specific events in a patient's life, such as a heart attack or a stroke or an amputation or prolonged hospitalization in which a patient doesn't have ready access to cigarettes? I think we've all heard anecdotally about people giving up cigarettes because of this or that big event, and we encourage that, but I didn't know if there's any studies looking at that or strategies that would be different from in an outpatient setting when you're encouraging tobacco cessation.
Yeah, that's a really good question. I did not look into that specifically as part of the scope of the presentation. I don't know if Dr. Cohen knows of any data on that specifically on life events and quitting smoking. Yeah.
Not aware of any specific.
Yeah. But that's a really, really good question. I'm sure there is out there, but I'm not sure.
Kind of quick comment and question. So I felt like for a while there was a really good headway on getting restaurants and other places to be smoke free. And I feel like with the vaping, that has kind of affected that battle. Did you come across anything while you were looking through your studies? Because I feel like we're having to restart the battle because people just assume vaping is safer, which we don't actually know if it's safer for the lungs, and we don't know if it's safer as secondhand smoke and things like that. Did you come across anything about that in the battle of
like limiting e-cigarettes?
Yeah, like limiting e-cigarettes in spaces. I've seen people just pull them out like in airports and airport restrooms, and I'm like, that I don't think that's supposed to be there.
Yeah. I did not, but to be honest, the fight against e-cigarette use is, I think, very new still, and it's definitely kind of down. I think it's probably on the agenda, but I didn't see anything specific about anybody like specifically looking to get that on the books.
Thank you.
Mm-hmm.
Tell them to smoke the 1 pack a day smoker. I say for this week, you smoke your 20 cigarettes. Next week, you map out 19 cigarettes.
Right.
And every day you smoke 19 cigarettes for that week.
Yeah.
The week after, you do 18 cigarettes. And also remember this, every time you pick up a cigarette, wait 5 minutes to light it.
Right. I found it real
That
helpful.
gives them a sense